here with Dr. Amy Luckenbaugh, joining us from Vanderbilt, and we're discussing highlights at this year's AUA meeting with respect to kidney cancer. So thanks so much for joining me, and I'm really interested to know what you're taking home from this year's meeting and how your practice is going to change based on what we've seen this year.
Yeah, thank you so much for having me. There have been a lot of really good both posters, podiums, as well as plenaries on kidney cancer this year. There have been a lot. One thing that I think is really changing potentially or groundbreaking is the diagnostics in the girentuximab or zircon study, where they have done a pretty good job in looking at can an imaging test diagnose clear cell and potentially avoid the need for a biopsy for patients. And so there is the tracer girentuximab, which they have given patients, and they'll be presenting that data in a late-breaking abstract form. And the data is really impressive. It has a great positive predictive value for clear cell renal cell carcinoma. The caveat to that is it doesn't necessarily say if it is a negative study what this is. It could still be an oncocytoma, it could be papillary, it could be a number of other things. So I think that's one caveat to that. Just because the test is negative doesn't mean that there is no cancer. It just means it is not clear cell. But it is really interesting and can aid in active surveillance decisions and things like that for patients with clear cell in the future.
I love it. So how does this fit into your sort of practice paradigm? So, we're starting off with probably some axial imaging, a CT or an MRI. We're identifying a renal mass. Some of us are using renal biopsy these days. Sometimes the patient doesn't necessarily need a biopsy. You're taking them straight to surgery. So how do we use this additional information to change our sort of pathways in clinic?
Yeah, I think that's a great question. I think it depends a lot on whether the patient is a surgical candidate or not. I think there are times where there are people that we hope that this would be negative, and we can say, well, you don't need a biopsy, you don't need anything. I feel pretty happy watching you because you may have a slow-growing renal mass or a benign mass, and so for small renal masses under 3 centimeters, I think that is one utility. If it ends up being positive, you can provide them with information, hey, you still may be a good candidate for surveillance if you're a small renal mass, but people with clear cell may be more likely to come off monitoring. And so I think it can guide you in 2 directions. One, are you kind of safe to monitor, hopefully? Or should you be just saying, you know what, you're young, you're healthy, and you have this, and would you like to get it out now, or would you like to wait?
Absolutely. And so in your mind, is there a size threshold where we're using this? A large renal mass, do we need to get this new scan, or are we okay? My current paradigm is, you see a 6 centimeter mass, I don't need a biopsy, I'm happy with axial imaging, finish up my staging and take them straight to the OR. Do you think we need to fit this new imaging paradigm in there, or are we operating the same way we do today?
I probably personally won't use it for a large renal mass once it is available to us. I think that in those cases, I would, and it wasn't certainly done in large renal masses. It was done for T1, so stage 4 centimeters or less, and so we don't really know the utility in large renal masses. I think what will be interesting to see is going forward in a metastatic setting, can it be used to identify clear cell metastases that other imaging can't? And that is not known, but that will be interesting to see.
Yeah, absolutely. And I think when we look at other settings and other ways we can combine it, if you look at sestamibi and maybe combinations, really getting a bit more nuance on the histology, this maybe gives us the clear cell information. We use sestamibi in those more oncocytic kind of lesions and maybe tease out a bit more detail without intervention. Any other thoughts in terms of intervention data you've seen here? I think there's been a fair bit of partial nephrectomy data presented, and any thoughts on how that maybe changes the way you approach your next OR day?
I think there's been a lot of data in a lot of podium and poster sessions about 3D modeling and how that can change practice. And there are some really good models out there that seem like they actually do a good job, a better job than a CT scan for surgical planning. And I think those will probably become more and more popular. They don't change my practice right now. I don't have access to them, but I think that they've shown, a lot of studies have shown you have reduced warm ischemia time, reduced likelihood of progressing to a GFR of less than 45, less than 60, and things like that when you're using these 3D models. So I think that will be interesting in a technologic advancement that going forward. And then there was one very good paper that looked at complex renal masses defined as a renal score of 10 to 12 that looked at whether doing a complex partial versus a radical helped prevent decline in GFR, and in long term it did out to 3 years. Those who had the radical had worse outcomes in terms of their GFR, declining to both less than 60 and less than 45. And as opposed to those who had the complex partial, actually most of them had a little decline and then maintained. And there were more complications in the partial group. However, there was no difference in major complications. So they're kind of pushing the paradigm of doing a complex partial is probably worth it. And that probably should be done a little more, and especially in patients who are worried about their renal function.
Yeah, absolutely. And I think, maybe taking that to the furthest extreme, I saw, data from the SUO session looking at the role of a cytoreductive partial nephrectomy. And so we're really pushing the paradigm in terms of the patients we're thinking about leaving nephrons behind in. Any other data that sort of struck you from this year's meeting?
I think the last thing that really struck me is we have this huge gap of, we have immunotherapy. What should we be doing after people? Should we be doing a cytoreductive nephrectomy prior? Should we be doing immunotherapy, and if everything responds, taking out a kidney? And I think that is something that there's evolving data. There was some prospective data collected, and about 9% of people in this one cohort, small population, but one cohort, had a complete response from immunotherapy and had T0 disease on their nephrectomy. And those people who had that 3 years after surgery, 100% had 100% disease-free survival, 100% overall survival compared to those who had residual disease. And so I think, who are these patients? Do we need to take out their kidney if they're going to be T0? And I think that, what are we going to do with this in the future? I think that's huge. And who knows? I think we're probably maybe heading back towards cytoreductive nephrectomy in the immunotherapy era, but I think that's kind of remains to be known.
Yeah, I agree. I've certainly done a few. I don't know what your experience is. I found many times they're very doable, and on occasion the tissue planes are absolutely atrocious. But you really wonder, maybe those are the patients we didn't need to do a cytoreductive nephrectomy on, and you really hope that maybe you can get the patients where you're doing a true consolidative nephrectomy and you're taking out a burden of disease that's left behind. But yeah, there's obviously huge important prognostic value that you've highlighted. The patients, just like in bladder cancer, if we get T0 resections at the time of cystectomy, and clearly there's ongoing work, Betsy Plimack and others trying to figure out who the patients are that we can leave those organs behind after their systemic therapy. But obviously lots of interesting and forward-looking data and exciting things for the next meetings to come.
Yeah, absolutely. I can't wait to see what's coming next, specifically for that immunotherapy and kidney era.
Perfect. Well, thank you so much. Really appreciate your time.
Thank you.